Good afternoon and welcome to the monthly Senior Fellow Society webinar. I'm delighted to welcome and introduce Matthew Garrett, who's Dean of the Faculty of Dental Surgery. It is perhaps not widely known that on retirement, FDS Fellows are eligible and indeed very welcome to join the Senior Fellow Society, and so it is appropriate that we hear from the Dean. Matthew is a consultant in restorative dentistry at the Eastman Dental Hospital and leads clinician in prosthodontics. His main clinical and research interests are the oral rehabilitation of developmental and acquired dental anomalies, head and neck oncology, and developmental defects of enamel and dentine. He's been an examiner in restorative dentistry as well as chair of the SAC in restorative dentistry. He was elected Dean of the Faculty of Dental Surgery of the college in 2020. I must say it is depressing to hear that the most common reason for a child aged between 5 and 9 admitted to hospital for a surgical procedure is to have dental extractions under general anaesthetic. And so it is timely that Matthew will be discussing children's oral health today and how the faculty is responding to the problem. As usual, please put any questions on the chat line, which is on the right-hand side of your screen, and Matthew will address them at the end of the talk. And so, Matthew, it's over to you.
Thank you very much, Irvin, for that kind introduction. It's a sort of shame that we're not meeting face to face in the college today, but we've just received an email actually to say that the new building work has been completed and the college is open. So when restrictions lift, hopefully we can meet once again face to face and enjoy company and the social part that goes with it. As Irvin said, I'm the Dean of the Faculty of Dental Surgery and have been doing that job now probably for about just over a year. The job is part-time, so I spend half of the week as Dean and then half of the week as a consultant at UCLH in central London. And as you've heard, it's in the Department of Restorative Dentistry. One of the things that I inherited from a number of past deans was the issue over child dental health and the ongoing problems regarding the health of the nation's children. So I'm here really to talk to you a little bit about that, a little bit about the strategies that the faculty have adopted to try and help the issue, and also to talk probably quite a lot about the effects of community water fluoridation, which hopefully will be introduced relatively soon, but has been on the cards for a very long time within dentistry. I'm very grateful to Simon Hershaw from NHSE&I, so National Health Improvement and in England for helping me with some of the statistics around some of the slides that you'll see a bit later on this afternoon. So let us begin by looking at the slides. I'm sorry that the slides are being controlled by the organizer, so I'm going to be saying next slide quite a lot, a bit like Chris Whitty does on the PM's catch up. So could I have the next slide, please? Thank you. So this graph here, and as Irvin pointed out earlier, he mentioned that the biggest reason or the most frequent reason for a child to be admitted to hospital is to have dental extractions carried out under general anaesthetic. And that's quite a staggering statistic. And I often wonder how well we're sending that message out to the general public. I often ask my trainees, we haven't done the study, but if you were to sit in, Oxford Street, for example, and ask the first 100 people that walk past you what the biggest reason for a child to be admitted for a surgical procedure into hospital was, how many of them would say to have their teeth taken out? I suspect we would have quite a lot of people saying tonsillectomy, etc. But I doubt that many people will say, well, I'm not sure, but I wouldn't suspect that many people would rate extractions as the most common reason. And it's very sad to hear that, particularly as a dentist, because of course dental disease in terms of dental caries is an entirely preventable disease. So as I've said, dental extractions remain the most common reason for children to receive treatment in hospital, and unfortunately the situation is getting worse. And this graph, I think, helps to show us that significant inequalities persist, with, unfortunately and sadly, rates for admission for tooth extraction in the most deprived communities are nearly 4 times that of those living in more affluent communities. And this is a headache which I have inherited, as other deans have as well. And and it is really not an acceptable way forwards. Could I have the next slide, please? So this shows you the fiscal cost for what is, as I've mentioned already, an entirely preventable disease. And we also have and expect COVID to have a major negative impact. And of course, I suppose the lessons from the pandemic is that we need levels of prevention resilience. And I think there are things that the faculty can help support to do this, particularly with the use of community water fluoridation, which I'll come on to speak to you a bit later on, and also about supervised toothbrushing programs, which exist in Scotland, but actually don't exist yet in England. Could I have the next slide, please? So this tells us what the faculty have done so far. Back in 2015, when Nigel Hunt was the dean, we published a policy report on the state of children's oral health in England, with various recommendations, including things like introduction of sugar tax, junk food advertising to be limited on televisions and in other social media contexts, for sugar-free schools, and also for community water fluoridation regimes to start happening. As a consequence of that position statement and policy report, we established a debate on child oral health in the House of Commons in 2017, and then we updated our position statement again when Boris Johnson became Prime Minister. The press are very interested in this, and I'm often asked to speak at various radio stations and television interviews. And in fact, you can see there that between the 1st of March and the 8th of June this year, we received 556 media mentions for child oral health stories. So it's encouraging that the news is getting out in the wider population, but still there's lots of work to do, and we've got a lot of work still to do. Could I have the next slide, please? This is a pyramid which looks at priorities for public investment in oral health, and it was carried out by a chap called Professor Jimmy Steele, who was a consultant dental surgeon who was based in Newcastle and unfortunately died in 2017 of a brain tumor. But he published this review called the Steele Review in 2009. And the Steele Review was an independent review of NHS dentistry commissioned by the Department of Health, for which Jimmy was awarded a CB in 2012. And his goal really was to ensure that patients received the best and most effective care possible. And the review considered priorities for public investment in oral health. And we have the so-called Steele's pyramid, which clearly shows that public health initiatives have the highest priority for public investment. So what do we mean by public health initiatives within dentistry? And could I have the next slide, please? So we've got evidence already that public health programs work. I already mentioned the sugar tax, which is more formally known as the soft drinks industry levy, which resulted in 30% reduction in total sugar in soft drinks. And what that has done is to remove millions of metric tons of sugar from soft drinks, and appears to be shifting consumer purchasing to healthier options. Those of you who follow the football may have seen an interview with Ronaldo not that long ago, when he removed 2 bottles of Coca-Cola from him in front of the press conference and said to drink water. So these sorts of messages from people like him are absolutely the right thing that we need to think about. It's also, I think, worth highlighting the fact that often people think that sugar-free drinks or sugar-free fizzy drinks and diluting juices are safe for teeth. They're absolutely not safe for teeth, because they do contain natural sugars and also carbonic acid, and the acid content of those drinks, although the sugar, the sort of synthetic sugar levels are relatively low, are doing a huge problem in terms of the amount of tooth wear that we're seeing through acid erosion caused by those types of drinks. The message really is that the only safe drinks for teeth are plain milk, so plain water, plain milk, and tea and coffee without sugar in it. So trying to maybe persuade one's patients that that's the right thing to drink all of the time is a challenge. But you know, I think we're getting there, and I think that the sugar tax has helped us. The sugar tax, incidentally, has also raised about £340 million for the Treasury. Next slide, please. So as I've said, although we've done a reasonable amount, I think there is more to do. And more can be done to target resources at outreach programs which are aimed at poor health and inequality pockets in the communities. Programs, for example, reducing barriers to access for socially marginalized groups, focusing on things like care homes and special educational settings, so special schools, for example, supporting access to care, supervised toothbrushing programs in deprived areas are all possible and were included in the Chief Dental Officer's transitions to a better future proposal, which was a document which was released by the English Chief Dental Officer. And interestingly, dentists are also very supportive of this. There was support at last month's local dental committee conference, where 88% of conference attendees supported urgent program development to meet the inequality challenges within the population. The next slide, please. And of course, the other way we can do this is through community water fluoridation. And I've mentioned this previously. It's not new, but in fact, it's coming further onto the agenda. Next slide, please. So the community water fluoridation program began in Hull in 2011. And at that time, there was quite a lot of work going on in Hull to improve poor oral health, particularly amongst children. And you can see from this graph that in 2011 and between 2011 and 2012, Hull had very poor 5-year-old decay statistics. But it's not just the very poor levels in Hull that's striking, it's the inequalities that exist. If we look at the bar for Harrogate and Rydale and North East Lincolnshire, which is an area with similar levels of deprivation to Hull, but has much better levels of decay. And that's simply because this area has a fluoride scheme, whereas Hull does not. Next slide, please. So this slide highlights the facts that the college are pushing, the faculty is pushing, resulting from the introduction of community water fluoridation. So community water fluoridation reduces dental decay in children on average by 26%, increases the number of children within the population who have no decay by 15%. It can reduce dental health inequalities. And actually, more importantly, maybe for us working in hospitals, is that the numbers of general anesthetics are significantly reduced. And of course, I have to say that, you know, the first introduction that an individual has, a child has, of dentistry. I'm not a pediatric dentist, but I've worked in pediatric departments, both in London and in Scotland, and in the Midlands as well, actually. That actually, if the first episode that these individuals are getting of dentistry is being put to sleep to have, you know, 20 baby teeth taken out, then that's not a great start to dentistry, and that's something that I would like to change over the next 2 years of my remaining deanship. Children in the deciduous dentition have 20 teeth, and as I've said, it's not uncommon for a child to turn up to have all of those teeth extracted under general anaesthetic. In fact, just the other week, I was talking to a family. They had brought a child into the hospital with them. The child needed some teeth taken out under general anaesthetic, and actually this child needed, I think it was 10 teeth, and the parents thought that was great because the older sibling needed 20 teeth to be extracted. So for some families and some children, you know, being put to sleep to have your rotten teeth taken out is almost a rite of passage, and that mindset is something that we need to change. Next slide, please. So how do we know those previous statistics that I showed you are correct? Well, we know it through years of research and review, backed up by clinical experience across both fluoridated and non-fluoridated areas, and I will show you some examples as we go through. Next slide, please. So not only does community water fluoridation have an impact on dental disease, it also has an impact on inequality. And in simple terms, if we look at this, if you look at the y-axis, you can see it says mean DMFT. So that means decayed, missing, or filled teeth. So that's what we use as a marker of dental disease, essentially, whether the teeth is decayed, missing, or filled. And as I said, in simple terms, by looking at this graph, we can see here that the red line, which is the non-fluoridated community, and we see the green line, which is the fluoridated community, we can see that as deprivation increases, so does the positive effect that fluoride has on decay experience. And this is a relatively old study carried out in 1999, but it's still relevant today, and it's relevant that we speak to various stakeholders that I speak to as Dean to get this message across. Next slide, please. And this recent slide from the northeast of England emphasizes exactly what I've been saying. In every single level of deprivation, fluoride makes a difference, but in the more deprived areas, the difference is bigger. Next slide, please. So let's have a look at some of the evidence from the northeast of England, where quite a lot of this work has been carried out. And it's a good area in which to demonstrate the effectiveness of community water fluoridation, because fluoridated and similar non-fluoridated areas are side by side. So on this slide that you can see in front of you, the green balls show fluoridated areas in the northeast, and the yellow balls show partial fluoridation, and the red balls show areas where there is no water fluoridation. And that we can see from it that the areas with fluoridation have less decay in 5-year-old children, and the rates of decay, which this graph is showing, are about double in non-fluoridated areas. Next slide, please. And then if we look at the children with abscesses or severe decay in their teeth in 2015 from the same area, it's clear that there's a big difference in acute infection and pain between children growing up in Gateshead, for example, where there is fluoride, and Newcastle, compared with non-fluoridated areas such as Middlesbrough and Sunderland. It's about 2 to 3 times the difference. And of course, children with abscesses or severe decay have pain, difficulty sleeping, difficulty with schooling, they get behind with schoolwork. So all of these things can have a very negative impact on a child's development. Next slide, please. And here are the rates of extractions across the northeast of England. Unsurprisingly, there is a trend of more extractions in Sunderland and Darlington, Middlesbrough, which are non-fluoridated, compared to Gateshead and North Tyneside, which are fluoridated, with over, as we can see here, sometimes 3 times the difference. Next slide, please. So with evidence that we have gathered over the years, together with the evidence that I've just shown you from those living in the Northeast, we can expect 59% fewer general anesthetics in fluoridated areas. And this seems to be the case in Teesside. Hartlepool has half the rates of general anesthetic extractions compared with non-fluoridated Redcar, Cleveland, and Middlesbrough. So it is actually very striking, the difference between the two populations. Next slide, please. And of course, community water fluoridation is stunningly cost effective. If we look at this, which has been released by Public Health England, it costs around £1 per capita per annum. And for that, it repays £22 for every single £1 invested after 10 years. Next slide, please. So how do we compare to the rest of the world? We can see that compared to Ireland, Australia, and the USA, we have poor coverage of community water fluoridation. But hopefully the recent white paper proposals, which will move funding arrangements from local authorities to central government, will help this change. Next slide, please. Because the proposals that have been put forward in the white paper effectively remove barriers to implementation. But in the short term, they may introduce some clarification issues for those local authorities wanting to move faster than they may otherwise move. Next slide, please. So Public Health England have produced this leaflet, which is being distributed to many dental practices, dental hospitals, social workers, etc., up and down the country, which gives a very clear outline of why we might need water fluoridation, what it is, and the risks and the benefits. There are risks to providing water fluoridation. It is, of course, a medicine. And one of the risks that you can see on this slide is that of dental fluorosis. Well, dental fluorosis is a developmental issue in relation to the enamel of the teeth, where the teeth can look white and speckled and flecked. When there is too much fluoride, in the water supply, or an individual takes fluoride drops or extensive or high strength fluoride toothpaste while the tooth is forming. But the community water fluoridation is talking of 1 part per million. So 1 part per million of the water supply, which is not enough to provide this level of dental fluorosis. We do see it within the hospital. So patients who come from places where there is a natural water supply, there is natural fluoride in the water supply, can get these discolored teeth, which can be quite difficult to treat actually. Some parts of rural Africa, for example, Somalia, they have fluoride in the water supply, and we see patients coming from those areas with white, speckled, fleckled teeth, and actually difficult to keep them clean, difficult to make them look aesthetically pleasing, although the additional fluoride, which has been incorporated into the tooth structure, does give the patient some protection over dental decay. Next slide, please. So we have worked hard to try and get the message out, and only a month ago, the Royal College of Paediatrics and Child Oral Health voted to support community water fluoridation, together with the faculty, obviously. And so we're trying to build up this relation of individuals or individual organizations who are sort of sending the same message out. And in February 2022, we're hosting a day at the college where we are going to look at excellence in innovation to help improve child oral health. So we're going to look at areas where there's been evidence in this. We're going to look at areas where there have been public health investment in this, and we're going to also look at some excellence in clinical outcomes as well. And what we're trying to do is to, as I said right at the beginning, to try and increase public awareness of this particular issue. So we don't really want a whole load of dentists to come to the meeting, or indeed pediatric dentists to come. We want other allied health professionals to turn up, such as pharmacists, such as social workers, and also to include teachers in that group as well, so that everyone is working alongside each other in order to help improve this awful issue that we have at the moment. Next slide, please. So there is a website which is here, and this is the British Water Fluoridation Society, and they are an important partner with the faculties and all other interested stakeholders with huge experience and knowledge in this area. And the BFS have got a new website. Membership is free, and joining that organization is a very effective way of demonstrating one's support for this issue. Next slide, please. So these are the headline facts regarding community water fluoridation that I've discussed as part of the talk so far, and these really have been developed as, easy, short, quick messages which we can get out there to try and communicate the issues via social media. So hopefully this will help in the future. Next slide, please. So in terms of things that the faculty has done going forwards, I've mentioned quite a lot already about community water fluoridation, and I've said that the government's health and care bill will will be able to grant the Health Secretary new powers to directly introduce water fluoridation initiatives rather than to be reliant on local implementation. In 2019, the Prevention Green Paper promised a consultation on extended supervised toothbrushing schemes to 30% of deprived 3 to 5-year-olds by 2022, but this is yet to be published, and we suspect that this hasn't happened at the present time. I mentioned before that they do have this toothbrushing schemes working in Scotland, and they appear to be working very well. Supervised toothbrushing scheme means that targeted groups of children, so in this case the 3 to 5-year-olds within those areas that I've mentioned that are most deprived, go to school, and in the morning they brush their teeth as soon as they arrive at school, and then they brush their teeth and are supervised in doing so when they leave school, so that we know that they've had fluoride on their teeth twice a day. And I think that would be a very cheap and a very effective way to try and help reduce these issues. We do, of course, see very good initiatives happening in isolated pockets, but actually we don't see that as a standard. And in fact, I was interviewed on BBC Radio London not so long ago by those of you who listen to BBC Radio London will know that the breakfast presenter is Vanessa Feltz. And one of the things that she asked me was, don't you think that families have enough to do before sending their children home, at school to school without having to worry about brushing their teeth? And then, isn't it the parents' responsibility to make sure that this happens? Or no, sorry, don't you think teachers have enough to do without worrying about brushing teeth? And don't you think it's a parental responsibility? And the answer to that, I suppose, is that it is a parental responsibility, but we see good evidence and good pockets of good behaviour, but also we see bad behaviour and bad pockets as well. So I think it would be much more standardised if it was something that we were able to do. Very recently, we were able to get our junk food advertising ban across the line, not just actually from a faculty's perspective and thinking about sugar, but also thinking about it from an obesity point of view as well. And you may have read in the newspaper recently that a 9 o'clock watershed on TV adverts for junk food will be introduced from 2023, alongside restrictions on online adverts too. And as I've said, of course, we've been working with other rural colleges because the obesity issue is a huge problem as well, particularly for the College of Pediatrics. And so the obesity issue, together with the dental issue, do sometimes go hand in hand. And that's where I hope that collaboration will happen. And that's what I mentioned previously about our day, which we're trying to put together in February, where I hope all stakeholders who have an interest in this will be able to engage with us. So we've also spoken to Save the Children and to NSPC as well. So these organizations are also on board to try and improve the nation's health. And the other thing was the sugar tax, as I mentioned earlier, the soft drinks levy, which was introduced in 2018, which encouraged reformulation of sugary drinks. And there are various companies that signed up to that, particularly Ribena and Iron Brew. They're the two that come from the top of my head. And as a result of that, the sugar content fell by 28% of those particular products. If the sugar content did not fall as a result of their reformulation, then they were to be charged extra tax. So that's where the sugar tax came from. but also the other issue, of course, is, as I pointed out earlier, that it's not just about the sugar content. It's about the acidic content of these drinks as well, which can cause problems to the teeth. So really, plain water, plain milk is the key to grandchildren, great-grandchildren, unless they're actually eating something. So it's actually the frequency in which they're consuming these fizzy drinks and sugary snacks rather than the amount. So if you have, one bag of sweets, then actually it's better to just eat them all in one go rather than eat one sweet every half an hour throughout the day, because the acid attack on your teeth and therefore the demineralization of the tooth hard tissue is happening more frequently, and it never gets time to come back to a pH neutral, or the mouth never gets time to come back to a pH neutral, and therefore the negative effects take over. And just could I have the last slide, please? So the last slide in my whistle-stop tour is just to show you the new building. So I hope many of you have seen the new building. I've seen it a few times, and it is absolutely a fantastic space. And I was speaking to Jackie Weller, and I said that I was coming to speak to the senior fellows, and she said if anybody wants a tour of the building before it officially opens, I think at the end of, I think it's in September it officially opens, do contact Jackie Weller, who will be delighted to take you on a tour of the building before that time. I've put up here, there are two links, one at the top, which is at Matthew_RCSENG, which is my Twitter feed, for those of you who sign up to Twitter, and also an at FDS_RCS for the FDS's Twitter feed. So please, if you are a Twitter follower, please do follow us so that we can update you with all the exciting things that the faculty is doing, not just in regard to child oral health. It's not the only thing that I spend my time doing. There are lots of other exciting things and initiatives that we're doing, particularly with the main college, and trying to be more aligned and work with the main college. The faculty actually has around 5,000 members and fellows, so it makes up approximately a quarter of the main college's membership. So it's not a small faculty, it's a large and thriving faculty, and we're doing lots of other exciting things and really looking forward to moving into our new home. You will also see my email address, which is mgarrett@rcseng.ac.uk, and of course I'm very happy to answer any questions that you might have, either regarding child oral health, if you want to come to the study day in February, or whatever issues or concerns you might have regarding dentistry, then please do drop me an email and I will be absolutely delighted to answer. So I said that it would be quite a quick whistle-stop tour. I know that everybody probably wants to go and have supper before they see football tonight. So I hope that that's been helpful. And of course, I'm delighted to answer any questions that anybody might have. So thank you.
Well, thank you very much indeed, Matthew. That was tremendous. An excellent review of a solitary, albeit rather depressing account of childhood oral health, but nevertheless, it is fascinating, and it is indeed a worrying issue. Can I just, before going on to questions, I've got just one question to ask, but before doing so, could I say how I would like to emphasize the point that you made about visiting the new building, which is absolutely tremendous. And we've got actually our annual general meeting on November the 17th, and Jackie Weller has offered to take us all around with a guided tour. So we will have the opportunity of having it shown to us by Jackie, and we look forward to that very much indeed. Now, there are actually, Matthew, quite a number of questions already. I've got one, but I don't think I'll have time to even ask you it. So I'm going to go straight forward to the questions from the audience. And this is from Mahmoud Karim. Pregnancy planning and gestation period are a great opportunity to promote health of the unborn child including dental health. So I presume the question basically is this a time in which you can actually start promoting dental health,
Yeah,
literally during this period?
yeah, I think, I think as well as pharmacists, social workers, midwives are also a key group of individuals who we need to get on board. So that's a really helpful question, a really helpful comment. One of the things that we have introduced or has been introduced, it's not a faculty initiative, but it's a faculty supportive initiative, is something called Dental Check by One. So this has been introduced by the NHS in England, where we would encourage and expect all children by the age of 1 to have had a dental checkup in order to try and highlight any issues, particularly again with feeding, people that children that go to bed with bottles of milk at night time, the milk is terrible because it sticks around the teeth and that causes what we call bottle caries. So we often see that. So, yeah, thank you for your comment. That's absolutely correct. This group of individuals, the midwives, I think we do need to engage with a bit more.
Well, thank you very much. The next question is from Martin Mate. In fact, it's a question that I was going to ask because I remember as a medical student, we're talking about a few years ago now, the whole question of water fluoridation was being discussed at that stage. And I just wonder whether, in fact, are there sort of anti-fluorinating water people? Let me just read out Martin Mate's question. He says it's more of a statement than a question, but the fluoridation campaign was already going on when I was studying in the 60s. I guess that's what I would say. And yet, as a consultant in maxillofacial surgery in the 1970s, 80s, and 90s, I was continuing to be forced to admit children for multiple extractions of decayed and infected teeth. What happened to fluoridation? Was it public opinion that refused it? I guess a number of people are perhaps asking that question.
Yeah, I mean, I think you're absolutely right. I mean, I qualified in 2001, and when I was a dental student, we were talking about water fluoridation. I think part of it is to do with logistics. I mean, I'm not an engineer at all, but I think there are problems with local authorities being able to actually introduce it into the water supply for various reasons, i.e. they can't do it very easily in one location without actually the neighboring region getting some fluoride as well. So there are all those sort of, infrastructure problems as well. And then, of course, you do have the anti-fluoridating, individuals who think that it's a mass medication and they should have the choice as to whether or not they have it or not. So there are issues from them as well. But I think by moving it from local to central government has to be a step in the right direction. And then it's not up to local authorities to sort their own infrastructure out. It will be guided more centrally, which has to be the right way forward.
Yeah. I guess on the same sort of theme, Richard Welfare, I think you know, basically says it's been known for over 50 years that fluoride is beneficial to the prevention of dental caries. However, the anti-fluoridation group have managed to prevent much progress with this. Their main platform has been that this is mass medication, and they have been very effective.
They
I
have.
think we should try to avoid the suggestion that fluoride will be added to the water. Rather, it is a supplement.
Yeah, perhaps that's the right thing. But I do think, I am sort of stunned in a way in that, we're sort of, I do feel that we're missing a trick in many ways, in that we haven't been able to get the message out, widely enough about the problems with child oral health and the actual cost the cost burden for a general anaesthetic, and and the multiple general anaesthetics that happen up and down the country, with something which is entirely preventable. And this is a very, very, very good public health way of doing it. And I just don't think, I don't know why, but the public are on the same page as the profession, and and that's a difficult thing. As I said, I really want one of my trainees to do this study where they sit in a major shopping center and ask, X number of individuals that walk past them, what is the most frequent reason do you think for a child to be admitted to hospital, and just see what the public perception is, because I just don't think it's there, and I think that's the problem. So all of this media attention that we're getting, I just hope is doing something.
Fine. This is from Derek Wilmot. Well done, Matthew, he says. Keep spreading the message. Fluoridation is a safe and effective way of reducing the misery caused to so many children and late adults. Also, the cost to the state and the potential risk, not to mention the overprescription of antibiotics that is occurring whilst patients are waiting.
Yeah, absolutely. And Derek is a former dean of the faculty and will be well aware of this, and also would have been, campaigning the same as me and other deans since Derek for this particular issue. So my job has been made much easier by predecessors who started this work, and I'm just building on it, and hopefully everyone will other deans will also continue to build on that work, because I think progress will be slow. I did say that in the next 2 years, when that I've got left, I would like to see dental extraction is not top of the list of the reasons for a child to be admitted to hospital, but the reality is that I just don't think that's going to happen. But it will one day, and I think all of the past deans will be absolutely delighted with that result when it comes.
I must ask one very quick question. That is, I was interested with a lot of the data you presented, but is there any direct correlation between oral health, social deprivation, and childhood obesity? In other words, are these three factors interrelated, and is there a factor weighting one or other of them?
Yeah, I'm not sure about the child obesity one. The other two definitely, but we haven't. I mean, what we do need to do is work with our, with College of Pediatrics as well to try and bottom this stuff out. So, collaboration is definitely the key.
Okay, a question from Nigel Hunt. Back in 2017, we were pushing for credentializing of dental practices and pharmacies who had an active children's oral health promotion system in place. Has this progressed?
Nigel is we should absolutely be doing that, and it's still high on my agenda that we do that, and I'm not sure that it has progressed as quickly as we would like it to have happened. So yeah, I know, because Nigel Hunt was actually the person that produced the first document around the state of children's health in England. So Nigel really did lay the foundation for this work and highlighted the problems that we have. So yeah, things don't move that fast, but it's definitely still on the list, Nigel.
There's it's an anonymous question here. A dentist once told me that if a child is not allowed to eat sweets for the first 2 years, they won't develop a taste for sweets. Is there any further research on that?
I don't have any evidence for that, but I think I've got other dental colleagues with children who don't give them any diluting juice or fizzy juices because they think, what they don't have, they don't know. But I mean, who knows what's going to happen when they go to school and they, can have got their own money and they can go to the tuck shop and buy sweets from the tuck shop. That's why we also calling, I guess, for sugar-free. The word sugar-free isn't liked by some individuals, or some groups. But actually, we are calling for a space during the day, i.e. when the child is at school, for that to be a sugar-free time. That's happened. And when I talked about, patchy patchy examples of good practice and bad practice. We know that there are schools that have introduced that, so got rid of vending machines, got rid of tuck shops, but there are also others that haven't done that. So, you know, that's what I mean about good and bad practice, but we're trying to push it for all schools. And, you know, that was a campaign issue that Nigel, for example, introduced a while ago. And, you know, as I've said, things do progress, but progress very slowly.
Another anonymous question: is sugar-free chewing gum considered to be helpful against tooth decay?
So yes is the answer, because it stimulates salivary flow, and saliva contains various antibacterial effects and buffering effects that can reduce the pH in the mouth to bring it back to normal. So sugar-free chewing gum is safe to chew. Yeah.
Fine. Samuel Apianan, health and care bill. Oh, this is a question. Health and care bill likely to pass? Question mark. Fluoridation provisions in the primary legislation, or to be invested in the health secretary, which is capable of being challenged. I think what it's basically saying, if it's not in there, are we going to challenge it, or are you going to challenge it?
Well, we will challenge it. Yeah, we will with other organisations that are campaigning for the same thing. Absolutely. I mean, you know, the numbers of stakeholders that the Dean meets and, you know, says the same thing to, you know, hoping that this is getting through.
Okay, I'm afraid there's lots more questions. I'm not sure how. Well, have you got a few more minutes?
Yes, of course.
Are you okay?
Yeah, of course.
It's
good to have lots of chat.
Oh, you've got lots of interest.
I'm sorry that we can't actually have a dialogue rather than it be like this. So.
Yeah, I know. I'm sorry about that also. This is a question from Jane Watkins. NHS encourages children to have a dental checkup before the age of 1, but most of the dental practices do not accept new NHS patients, including children. What's the NHS quota for dental practices? Actually, it's a pertinent question for me. I have a daughter who's in dental practice, and I must say it's pretty tough for them at the moment, as I'm sure you know. But yeah. Do you have any quotas?
Well, you know, the answer is I don't know the numbers for quotas for primary care. I mean, I think that you know, we are told that if you phone NHS 111 and let them know where you live, you should be able to receive care with an NHS dentist. I think that was one of Tony Blair's pledges a while ago. Whether or not it's come to fruition or not remains to be seen. But there is an issue. Well, there's not an issue, but the way that dentists in primary care are paid effectively is slightly strange. I mean, they're paid with something called units of dental activity. And 1 unit of dental activity is a different price for the dentist in different parts of the country. So it's not standardized. And also, if, for example, a patient needs 1 restoration or 10 fillings, then a dentist might only receive the same number of UDAs for that particular course of treatment. So it's supposed to be, you know, they're supposed to sort of have patients where they can sort of win on the system, and then patients when the system doesn't really work well for them, and it should overall even out. But there is some talk about reform of that contract. I'm not sure when that's going to happen, or if indeed it does happen, but I know that it is something which is being worked on by the Chief Dental Officer for England. So the way in which dentists are paid in England is slightly different to the way they're paid in Scotland. I know that, and Scotland has a different rate of disease. So I'm not sure if there are the same access problems in Scotland as there are in England. But don't quote me, because I don't have the data. But
I won't indeed. There's a question here from Selena Master. I'm aware that the pandemic has significantly increased waiting lists for paediatric GA extractions and conservation. Does the faculty have any figures on the effect this will have had, for example, on those waiting who may need more extractions than originally referred to.
Yeah.
Hopefully the oral health checks by the age of 1 will not have been too badly affected by COVID restrictions.
Yeah, I mean, let's hope not. I mean, as we know, practice is closed for a while, so there was no elective treatment, just emergency treatment. The numbers of individuals, it's difficult to actually get the data, Selena, so to know exactly how many children are waiting for general anesthesia, because often it's sort of mixed up within oral and maxillofacial surgery waiting list and oral surgery waiting list as well. So sometimes the data's not completely transparent. And I'm sure that, you know, there are, when the child in many instances turns up to have the extractions carried out, there are more teeth to be extracted than they were originally referred to, and I think that is certainly something that we should be looking into. There has been some work on something called silver diamine fluoride, which is painted onto the teeth. It's relatively easy to do and can be used in certain situations. And one of our pediatric dentists who sits on our board, Professor Helen Rod, has done quite a lot of research into this. So this product called SDF is painted onto the carious teeth before they become infected, essentially, and the SDF will arrest the dental caries, so it will reverse the process. But in reversing the process, it actually makes the teeth black, because the carious lesion, which was either previously white or brown, becomes black. So that could be a problem for children, you know, if they've got these black blobs on their teeth, because we know that children aren't necessarily the kindest to each other. So there are side effects with it, but it is something that is being looked at in the hope of being able to be used to you know, reduce the numbers that are requiring treatment. But watch this space, I guess, for that.
Yeah. Well, look, thank you very much indeed, Matthew. You'll appreciate by the number of questions you've received that your talk has gone down very well. It really was.
Just please do sign up for the, you know, Twitter feeds, the water fluoridation, because the more people that sign up to support these groups, the more, you know, the more likely our voices to be heard. So many thanks for asking me, Irvin, and hopefully we will all meet sometime, not too distant future now, it looks like.
Well, you never know. In fact, in November when we're there, we may bump into you. But look,
you may do.
On behalf of the society, I really want to thank you most sincerely. I mean, for taking the time to talk. I know at the moment you're in the middle of a clinic and you've broken off specially to speak.
Well, no, I've got only one patient. I've got only one patient. It wasn't. It was a bit lightly booked this evening because I want to get home as well to watch the match. So.
Absolutely. Anyway, we wish you well for your time as Dean, and we
thanks very much. And thank you.
Indeed.
Thanks for the questions as well, and the hospitality that we've had. So thanks very much.
Yeah, I've just got a few announcements.
Okay.
Basically, so if you want to carry on and start see your
I will leave. Thank you very much. That's very kind. Thanks.
Well, thank you very much indeed, Matthew. That was tremendous. I've just got a few announcements. There will be no meeting in August, and we will be meeting again on the 1st of September when Leslie Hamilton, who many of you know is a consultant cardiac surgeon, will be talking on gross negligence manslaughter, a topic which is, of course, of huge importance. Can I also mention again that we will be shortly sending out details for the AGM, which I've mentioned we hope will be held in the newly transformed college. And it takes place on the 17th of November. So please look out for the details over the summer, and hopefully you'll be able to join, and we'll have a very pleasant face-to-face meeting in November. So that's about it. But have a great summer. Have a relaxing summer. Enjoy the football this evening. Let's hope we have something to celebrate at the end of full time or extra time or after penalties. But in the meantime, keep well, keep safe, and we look forward to our next meeting online on the 1st of September. Good evening.